Welcome everyone to our session on epilepsy in North America, 15 years after the ILAE report. And I'll be co-chairing the session along with Amza Ali. And I'm going to start with a brief summary of what we found in the original report, and then the other speakers will bring us up to date since then. So we can go right ahead and start the first video. Welcome to our session on epilepsy in North America, 15 years after the ILAE report. I will give a brief summary of what we found in the 2006 report. Amza will speak on the English-speaking Caribbean, Cheryl on the US, and Sam on Canada. Here are the list of countries included in the ILAE North American region. They, of course, vary in population and in income per capita and a number of other health-related features, as well as health expenditure. But all of them, in terms of the UN Human Development Index, are in the medium or high range of countries. Health resources and spending vary. In the US, medical centers have become sources of civic pride comparable to late 19th century railroad stations or medieval cathedrals. Medical schools are named after major donors. People speak of the medical industrial complex. However, the US has worse outcomes than many other countries, despite the highest spending on health in the world in terms of GDP. Canada achieves better overall outcomes, for example, for infant mortality with lower spending. The ESC faces limited resources and organizational issues, in part due to having multiple relatively small countries with geographical separation. There was limited epidemiologic data available. Incidence in the US and Canada was about 40 to 70 per 100,000. Prevalence slightly higher in the US, 6 to 8 per 1,000 than in Canada. And some data suggested higher rates in African Americans. There was very limited ESC data, some from the Cayman Islands, and also some older US data showing variability across the age span. Socioeconomic issues were prominent. People with epilepsy have lower health-related quality of life, substantially lower income, and less likely to be full-time employed. And in the US, a markedly increased lifetime suicide prevalence. In the ESC, very strict driving rules were certainly then a serious problem for people with epilepsy. And interestingly, in Canada, data showed that people with epilepsy had a quality of life substantially lower than those of other chronic diseases. For example, on the psychological general well-being scale, you can see that other chronically ill patients very close to scores for the general population, but people with epilepsy are substantially lower. Stigma was diminishing but persistent. In the US, more marked than for other chronic diseases, and more likely to be expressed by those from lower socioeconomic groups with lower educational status and older patients. Interestingly, the public overestimated the severity of epilepsy. Greater stigma effects occurred in children and adolescents with epilepsy. In Canada, people who had less familiarity with epilepsy and a shorter duration of stay in North America were more likely to ascribe epilepsy to supernatural causes, as was also the case for rural populations in Jamaica. Epilepsy care personnel in the US were highly concentrated. For example, here's New York, here's Massachusetts, here's Maryland. Although up to 40% of US neurologists considered epilepsy a practice focus. At the time, there were about 80 epilepsy fellowship programs. Now, of course, that has become an official sub-qualification of the American Board of Neurology and Psychiatry. There was a better distribution of epilepsy specialists in Canada, but in the English-speaking Caribbean, there was a single epilepsy specialist in Jamaica. There were marked treatment access disparities, although not a great deal of evidence. In the US overall, a much higher proportion of minority groups are uninsured, and Native Americans and undocumented immigrants had particular access issues. At least 10% of people with epilepsy were found to be untreated. Treatment was often delayed, and even if people were insured, they could often skip doses due to high copays. Canada had theoretically universal coverage with some issues related to resource management. Here you see a map of the US showing that there is an interaction between factors of population distribution, minority status, and income in determining access to health care. In the English-speaking Caribbean, there was wide regional variation with limitations of public sector resources, delays in new anti-epileptic drug availability, and limited access to epilepsy surgery. So we had some recommendations for regional cooperation, such as encouraging chapter formation and holding international conferences. Some of these have been implemented. Developing country support for educational initiatives and assist efforts to reduce stigma, and develop regional referral syndromes to maximize the use of resources, and involve all countries in research, particularly on epidemiology. We should suggest genetic issues and clinical trials. So now I'm going to call on our other speakers, starting with Amza, to discuss what the situation is today. Thank you very much.
Okay, unable to start video. There's a problem with my, all right, start my video. Okay, good. So I want to mention that none of the speakers has any conflict of interest. And now I would like very much to introduce Dr. Amza Ali. Amza trained in neurology at the National Hospital for Neurology and Neurosurgery, Queen's Square, and has UK specialist certification in neurology, and then trained in epilepsy at Columbia. He's a diplomate of the American Board of Clinical Neurophysiology, and he is director of the Epilepsy Center of Jamaica and head of research in neurosciences at the University of the West Indies at the Mona campus. He also has an MBA from the University of Toronto and is involved in a doctoral program in healthcare economics. He's driven by a deep interest in sustainability in the context of specialized healthcare, particularly for epilepsy, and he is the immediate past president of the Epilepsy Society of the Caribbean. So we're looking forward very much to Amza's talk.
Thank you for the opportunity to speak to you on the subject of providing community support and education in Jamaica and the English-speaking Caribbean. I will speak to the activities of the last 15 to 20 years and speak to current challenges. 15 to 20 years ago, the situation was not good. We faced a significant treatment gap in figures that were available for Jamaica at the time of nearly 62% in children. There was a widespread lack of knowledge, misinformation, and stigma, which we crystallized in the term of the 4 Ds, characterized by the distance of affected people from facilities, a wide diversity, both ethnocultural and social, in the society towards epilepsy, disparities, particularly economic, in care, and the presence of detractors, namely people who did not support the idea of doing something for epilepsy. Stigma permeated all sectors of the Jamaican society as listed there. And to address these medical and social needs, we formed 2 chapters. The chapter of the ILAE called the Jamaica League Against Epilepsy, and the Jamaica Epilepsy Association, led by Mrs. Nora Perez, a chapter of the International Bureau for Epilepsy. And together we began working very closely. We recognized right away that money was needed. And here I have to acknowledge and congratulate Nora for all the hard work that she's done over the last 20 years, being so innovative in finding different ways to raise money through chorales, through calendars of famous Jamaican women, through a children's book for epilepsy, and through an annual fun run that over the latter years has become more a fun walk for the original founders. Education, of course, was the highest priority, and we started doing education in schools. And again, this was an initiative led principally by the JEA. The focus was on improving the knowledge of children with epilepsy and also parents of children. Equally too, we recognized that teachers needed a lot of education and support so that they could better manage problems as they arose for their pupils. We also recognize a significant need for educating nurses who indicated to us that their curriculum, their formal curriculum, did not expose them enough to epilepsy. And they too had many misperceptions and misunderstandings, which we were able to address by the partnership between the JLAE and the JEA in educational activities for the nurses. At a regional level, one cannot underestimate the significance and value of the NAECs, the North American Regional Caribbean Congresses on Epilepsy, which, although focused principally on medical education, had a significant community and social focus. Issues like driving were highlighted and have risen to prominence. A significant percentage of the attendees, particularly in the Eastern Caribbean, were not healthcare practitioners, and that was also very important too in reducing stigma in the broader society. Issues of access to care were very important and were highlighted in every one of these biennial events throughout the region. It was also important to find and involve key stakeholders, including the government and business sector, for obvious reasons, to be able to help the social needs of people with epilepsy. Again, the focus was principally on the Eastern Caribbean, especially in the earlier days where the needs were even greater. I cannot, again, underestimate the value of the close working partnership that the JEA had with the JLAE, and in time, I hope and expect with the Regional Epilepsy Society of the Caribbean. Working together and succeeding together help to strengthen relationships and further define the mutual purpose of addressing all the needs of people with epilepsy in the Caribbean. A strong focus throughout all of those NAECs was community education, and very often this would take place in the days before the actual formal agenda. And here too, I would like to thank many of the visiting faculty who participated in these activities. And we were doing so well. And then came COVID-19. The Caribbean did quite well with managing the first wave of the pandemic, but that was principally through shutting down. But you can't remain shut down forever. And the second wave has had an even greater impact. not only in terms of the number of cases, but because of population fatigue with the strict measures that were required in the first wave. Also an effect on physicians, both in terms of illness and the psychological burnout that has taken place because of how long this has gone on. And undoubtedly too, that epilepsy has suffered because of this acute and urgent medical pandemic. Many other conditions such as cancer care have also suffered. And there has been a problem of misdiagnosis because disorders such as dengue viral infections have become misdiagnosed as COVID, and vice versa too, leading to a lot of confusion and uncertainty out there. What specifically has this meant to the epilepsy agenda? We have had a major delay in getting video EEG and long-term monitoring equipment from Colorado because quarantining for 2 weeks makes travel logistically very difficult. There's been a loss of momentum on relationship building across the Caribbean and for working on specific projects such as the ILAE Driving Task Force. And fundraising, of course, has been very difficult, where in-person events can no longer be held. But never waste a good crisis. And there has been an opportunity here to advance a very important agenda that we have always wanted to do across this region, this dispersed region, the Caribbean, and that is telemedicine. This has been driven mainly by a fear of patients coming to hospitals and a growing acceptance of virtual technology. It also has advantages in that it has lowered the cost of patients coming for in-person care, and it has facilitated conversations intra-institutionally and even across the region. Family members now join in on conversations to participate in understanding and the care of individuals affected. But of course, there are challenges, especially for older people with technological unfamiliarity. And as people have been losing jobs and households become consolidated, an increased demand on bandwidth and therefore slower internet speed has made conversations sometimes difficult. At an organizational level, it has helped greatly facilitating meetings and will, I am sure, help to reactivate the relationships between the IBE chapter, the JEA, and now the Epilepsy Society of the Caribbean. It will facilitate, I am sure, being able to organize more easily regional education events as the first North American Epilepsy Congress no doubt demonstrates with the much wider attendance possible because of this format. I think we can summarize the current status of epilepsy care in the time of COVID by revisiting the 4Ds, recognizing that distance has been reduced virtually through teleconferencing. Diversity remains, but stigma has been lessened. Disparities are magnified now because of the economic impact of COVID-19. And happily, detractors are far fewer than 15 years ago, partly because of improved knowledge, but also because of including them in a multidisciplinary care approach, and therefore limiting and lessening the impact of outliers. Demonstrated schematically in this octopus, with the challenges at the top of the 4Ds and stigma, countered by education and strategic partnerships, especially with key community members. The JEA has worked closely with the JLAE and now progressively with the Epilepsy Society of the Caribbean. And through authentic leadership, that is, leaders who truly believe in what they're doing and who they are doing it for, and involving constantly younger members and younger team members to effect change, I believe, is ultimately the best formula. Effective epilepsy advocacy is all about finding balance, and for the limited numbers of healthcare practitioners who have been involved in this initiative simply because of the paucity of neurologists and specialized physicians throughout the Caribbean, that fine balance is required between one's clinical obligations and academic obligations, relating to one's colleagues, as well as the important need to support the social agenda, and which indeed really involves all other stakeholders. In the end, the race is not always for the swift, but for the steady. But we should always aim high. And a sad footnote to all of this is that even Usain Bolt is now down with COVID-19. Thank you for the opportunity to speak on this.
So thank you for that terrific and very insightful talk. We're going to have time for questions and discussion at the end so that all of the panelists can speak together. And now I would like to introduce Cheryl Hout. So Cheryl is Professor of Neurology and Director of the Adult Epilepsy Program at Montefiore Einstein and Chief of Service of Neurology at Montefiore Einstein. She has served as Chair of the North American Commission of ILAE and is currently co-chair of the ILAE Leadership Task Force and the Leadership Training Program, and is a board member of the American Epilepsy Society. She maintains an active adult epilepsy practice at Montefiore Medical Center. And we're looking forward very much to Cheryl's talk.
Hello, my name is Cheryl Hout, and I will be discussing epilepsy care in the United States after the Affordable Care Act and the Institute of Medicine report. So we'll touch on the impact of the Affordable Care Act, or the ACA, which was signed into law in 2010. We'll be discussing the Institute of Medicine report, which was released in 2012. I'm going to review briefly some CDC, or Center for Disease Control initiatives, and finish with the impact of the COVID-19 pandemic on epilepsy care in the United States. So the ACA, or the Affordable Care Act, was a critical act towards protecting the health care of individuals with epilepsy in the United States. You see here President Obama signing the ACA into law in 2010, following an extensive political initiative that came to fruition and was put into effect in 2014. And some elements of the ACA were very important for persons with chronic disorders, including epilepsy. The first of which is that all pre-existing conditions and chronic illnesses, including epilepsy, must be covered without limitation. Insurers could not deny coverage based on pre-existing conditions. Insurers may not discriminate based on an individual's medical history when it came time to renew coverage. And plans may not base cost on an individual's medical history or condition. So all of these together combine to be a very important protection for persons with epilepsy. There were some exclusions, and if you're interested to see that, this is all very clearly delineated on the ACA website. Furthermore, young adults were now covered up until the age of 26. In fact, under some plans, the coverage extends through the calendar year of a child becoming 26. And this included married children, children not living with their parents, children in school, etc. So this really expanded the coverage opportunities for dependent children or even independent children. And certainly for individuals with epilepsy, this extended the period of time for them to seek other forms of insurance. And then finally, some very important aspects of lifetime and annual limits. In the ACA, the health plans are prohibited from putting annual or lifetime dollar limits on most benefits received. Previously, you could reach a peak, and so, for example, a person with epilepsy who had multiple hospital admissions or ED visits in a calendar year may have reached a point above which they had to pay for their own medical care. This was now excluded from coverage, such that these annual or lifetime limits are no longer in place. It's extended to coverage for preventive services, elimination of the prescription drug coverage gap known as the donut hole, in which patients would run out of their prescription coverage often by October or November. And these elements are of particular value given the high economic cost of epilepsy care. And if we look at the ACA 10 years later, you see that recently, in March of this year, there were 25 patient and consumer groups, including the Epilepsy Foundation, which issued this statement recognizing the importance of the ACA towards protection of health care for many individuals, and certainly including those with epilepsy. So the ACA was a very positive and important step towards epilepsy care in the United States. Moving to the Institute of Medicine report, as you may know, the Institute of Medicine takes on certain disease states and studies them and issues updates and recommendations. And the epilepsy community was very pleased to know that in 2010, they were undertaking a look at epilepsy. You see here the IOM committee that was put together, including many of our most prominent individuals in the field of epilepsy, and the sponsors ranging from governmental sponsors to nonprofit advocacy organizations, which came to be known as Vision 2020. And the committee was tasked to focus on these 4 areas, ranging from public health surveillance and data collection, population and public health research, health policy and human services, and education across the board, providers, persons with epilepsy, their families, and the public. And some of the important findings that came out of the IOM report include an updated estimate of the prevalence of epilepsy in the United States being at 2.2 million people, the incidence being 150,000 cases per year. And this metric of 1 in 26 people in the United States developing epilepsy at some point in their lifetime was a very important element of the outcome of the IOM report. This is something that is very accessible. If you describe one child in a classroom as an example, you can start to visualize how big of a problem epilepsy is. The IOM report reinforced the previous data that the age-specific incidence of epilepsy is highest in children and older adults, and very importantly, identified that epilepsy is the 4th most common neurological disorder in the United States after migraine, stroke, and Alzheimer's disease. And this information is, of course, very important for research funding and delineating the scope of epilepsy in the burden of neurological disease in the U.S. You see here what the report looked like. It was called Epilepsy Across the Spectrum, Promoting Health and Understanding. This is available for free as a download from many sites on the internet. And there were 13 specific recommendations that were separated into these categories. And here you see 11 of these recommendations ranging from validation of definitions, criteria, instruments, surveillance and data collection efforts, early identification of epilepsy and comorbidities, quality measurement and improvement. From the professional point of view, there were guidelines to establish accreditation of epilepsy centers and networks, improve healthcare professional education about epilepsies, and then looking at the public, coordination and delivery of community services, educational opportunities for patients and their family, media opportunities to inform the public and reduce stigma, and overall enhance public awareness efforts. And post-IOM, you see that there has been a significant amount of work that's ongoing. The ELC, which is the Epilepsy Leadership Council, was formed from the governmental and Vision 2020 working groups. There's the CDC's Healthy People 2020, which includes an important element of epilepsy. There have been multiple publications, some workshops. The sudden death registry of the NINDS and NHLBI has been expanded to include SUDEP. And there have been the development of epilepsy curriculum tools and instruments. These are the Epilepsy Leadership Council members, and here's some examples of research that have come out in publications, of many. Briefly, the CDC created the Managing Epilepsy Well Network in 2007, which focuses on many epilepsy self-management programs that you can see here that have been of tremendous help for patients with epilepsy. I mentioned Hopscotch, PACES, and Time. Many of these are web-based or app-based and really help patients with self-management, self-awareness, and cognitive training. And finally, what we're all very aware of is the impact of the COVID-19 pandemic on epilepsy care in the United States. This is some preliminary findings from a report that we submitted from my institution here, Montefiore Medical Center in the Bronx. We were certainly in the hotspot of the COVID pandemic in March, April, and early May here. And some elements that I want to point out include that a third of our patients felt that they had worsened seizure control during the pandemic, and we found that patients who reported stress and poor sleep as triggers had a significant relationship to having worsened seizure control during the pandemic. We think that's very interesting. And then very important for public health and our community is that during the surge here in New York, many of our patients had difficulty obtaining medications, getting through to the pharmacy, getting through to their neurologists. And this is something that we must spread to other areas of the country as they go through surges, as well as the rest of the world. In good news, we found that video visits were well received and effective. So thoughts and next steps. Once again, the ACA has created tremendous benefit for persons with epilepsy in the United States, ensuring coverage without exclusion. The IOM report similarly has had a very positive outcome, and the Epilepsy Leadership Council is tasked with carrying out these IOM recommendations. I'll call out the CDC again for many self-management and self-awareness programs for persons with epilepsy. And finally, what we're dealing with now in some sort of a new frontier is the impact of the COVID-19 pandemic on epilepsy diagnosis, treatment, and hopefully prevention in the United States and internationally. Thank you again for participating, and we'll be taking questions at the end.
So thank you very much, Cheryl, for that terrific talk and for sharing with us the fascinating preliminary data that you have on the effect of COVID. So our final speaker needs no introduction, of course. Sam is professor of clinical neurosciences and director of the epilepsy program at the University of Calgary, and also leads faculty-wide clinical research. He is president of the International League Against Epilepsy. Sam.
Greetings, everyone. My task in the next several minutes is to review with you whether the Canadian healthcare system is the ideal healthcare system. And for this, we will look first at some features of a Canadian healthcare system, whether what is the ideal healthcare system, if it can be defined, and then finally, who is happy and who is unhappy with the healthcare system. So the Canadian healthcare system was born in 1966 in the province of Saskatchewan, and then the Canada Health Act came into being in 1984, and it has 5 overarching principles. Public administration, which emphasizes operation by nonprofit public health authority. A comprehensiveness, which has to do with coverage of all medically necessary hospital setting services. Universality, which has to do with insurance coverage of all insured persons. accessibility, which has to do with access to medically necessary services without financial or other barriers. And then portability, which refers to coverage of all insured persons when they move to another province or to another territory. Now, importantly, one should note that medically necessary services are not defined in the Canada Health Act, but it is left up to each province or territory to define it in consultation with physician colleges or groups. And if a service is deemed medically necessary, then it should be covered in full. Also, most provincial governments fund supplementary benefits such as dental, vision, and drug services and elements for certain groups such as low-income seniors and disabled individuals. So who is paying for what in the Canadian healthcare system? So this is data from the Canadian Institute for Health Information in 2019, and you will notice first that the percentage of the GDP devoted to health in Canada is close to 11%, as you can see here. Now, important to emphasize that this refers to both public and privately covered services. In other words, it's not just government spending. Of this total, which is about 7,000 per person per year, about 30% are covered by private sources, and of those, about half is out of pocket. Notice that there's a 3% per year increase. How does Canada fare in comparison to other countries? Well, you will notice here that as compared to the OECD average, Canada has a much larger GDP percent expenditure on health, which is only 8.8% for the OECD average. And you will also notice that in spite of that, the average OECD country spends more publicly in healthcare than Canada does, 73%. The countries in this part of the graph are organized in a descending order by GDP percent spent on health. And the highest, of course, is the US with almost 17%, and the lowest is the UK with close to 10%. And in the middle is pretty close, goes from 11 to about 10%. However, the US, as we all know, stands out. And important to note is that even though it's a country with the largest percent expenditure of GDP, really the majority is covered privately. Only 49% is covered in terms of public funding. Now, what areas are those that receive the most spending in Canada? Well, you can see that the largest expenditure is in hospital with over a quarter of the total cost. This is followed by drugs and physicians with about 15% each, and the highest rate of growth is among physicians with 3.5% per year. Now, it is important to talk about wait times because wait times are in the mind of all healthcare users in every system, and we've all experienced them if we've had to visit the health or be users of the healthcare systems. And benchmarks have been established in different organizations to determine what is an acceptable wait time. Now, these are data, again, from the Canadian Health Institute and from the Fraser Institute, and they determined that a reasonable time to wait for specialist care was about 7.7 weeks. And in Canada, the median is about 11 weeks, so about 3 weeks longer, 3 to 4 weeks longer. Now, this graph shows a comparison between 1993 and 2018. And notice that wait times have grown significantly, both in terms of the time spent from GP referral to specialist, here in the first darker area, and from specialist to treatment, which went from 5.6 weeks to 11 weeks, with a total of about 20 weeks wait times. Now, other benchmarks that have been established are for important procedures, and these are the benchmarks of the Canadian Institute of Health Information. It's about 180 days at the highest for hip and knee replacement, and 48 hours for surgical repair of the hip fractures with other elements, as you can see there. How does Canada fare in terms of the percent of procedures that are done within that benchmark? Well, you can see it here. For hip replacement, only 75%. It's even lower for knee replacement at 70%, and cataract surgery about the same. Higher for hip fracture repair, 86%, and then radiation therapy, almost 100%. And this may be related to the fact that difficult complex, expensive therapies are often instituted or accessed in a rapid manner in Canada, whereas more elective procedures such as cataract surgery, arguably fewer people achieve the benchmark wait time period. Now, when you look at what is the best healthcare system in the world, all you have to do is go to Google, type that, and you will come up with dozens and dozens of sites that use different systems, different ratings, to give you a ranking of countries in terms of what is the best healthcare system in the world. This is one of them. This is one example only. This is a World Population Review. And as you can see here, Canada rates number 30 in the world in terms of a ranking of the healthcare system, with the darker colors being worse rankings and then getting really bad in some areas here. But that just shows an example of what a ranking system would do. Now, the School of Public Health in Harvard has a blog on this area, and they have a publication that is interesting in their blog, which is possible checklists for the ideal healthcare system in the world. And they call this an ounce of evidence and judging health systems focusing on what really matters. And they came up with a possible checklist of 16 items, as you can see here, very specific items for developed countries. You don't see infectious disorders or perinatal care or infant mortality, because this really applies to developed countries. They are 7 subdomains, and they are in the areas of access, quality, innovation, and cost. Now, if you look at the areas, they're probably fairly reasonable. So how does Canada fare in comparison to other countries in this possible checklist for an ideal healthcare system? Well, here it is. In green are the areas where the rank was number 1 for that country. In red is where the country ranked last, number 8. And these are 8 different countries, as you can see here. And this is Canada. 8 of the rankings were the lowest for Canada, and 4 of the rankings were the lowest for Canada. And of those, 3 had to do with wait times. None were in number 1, as you can see here. On the other hand, you go to the United Healthcare System, and according to this rating, there were at least 5 number 1 rankings for the US, as you can see here, and only 1 where it was the lowest. According to this ranking system, the country that came on top was Switzerland, followed by Germany. You will notice that only 1 item is ranked number 1 in Switzerland, and there's a number 8. And then in Germany, there is no number 1s, and there's only 1 number 8 for various areas. So this is one possible way of ranking a healthcare system. Now, what about issues of opinions of the users with regards to how good a healthcare system is and how happy they are? Well, this survey by the Commonwealth in 2016 looked at 3 groups: people that were pretty happy, happy and unhappy, and then pretty unhappy. The first group has to do with the percentage of people that thought that the system was working pretty good, but only required minor changes. And here, the country that fared best was Germany, with 60% of people adhering to this view, and the worst was the United States with 19%. Now, in the other group was the question, the number of people or the number of respondents that adhere to the view that there were some good things about the system, but fundamental changes were necessary. And here, the country with the highest proportion was Sweden with 58%, and then the lowest was Norway with 33%. And then there was a group of very unhappy people that thought that the system should be dismantled and completely rebuilt. And here, the highest number of people adhering to that view was the US with 23%. And the lowest were Germany and Switzerland, in which people thought that the majority of people thought that system was pretty good and no real rebuild was necessary. How did Canada fare? Well, as you can see, 1/3 of people in Canada thought that only minor changes were necessary. What about the other 2/3? Well, about 55%, over half, thought that, yeah, there were some fundamental changes that were necessary, but there were some good things about the system. And only 9% thought that the system needed to be completely rebuilt. So what is the bottom line? Well, it is difficult to rate a healthcare system. What is the ideal? Well, it is not all about money. You can spend a lot of money in the healthcare system, and yet you will not have the best system. But it has to do with structure of the healthcare system. It has to do with efficient use of resources. It has to do, importantly, with metrics. How do you assess it? What metrics do you use? And then, extremely importantly, it has to do with preferences. Preferences to support certain aspects, and also preferences expressed by the users of the system. Thank you very much.
So thank you, Sam, for that fascinating talk. I have to say that I was amazed how well the US came out on the Harvard criteria. Makes you wonder. But now we are very happy to have a fair amount of time for questions and discussion. And don't see any questions yet in the Q&A. So perhaps, oh, here's one coming up now. Okay. So Jorge Berneo asks, is there any information on Native communities in the US and access to epilepsy care? So Cheryl, do you have any thoughts about that?
It's a great question, and as I know, Jorge has been involved in the past in we had a diversity task force some years back as part of the North American Commission. Clearly, there are tremendous disparities that exist. There are some publications on this, and you know, it's no surprise that the areas that are hardest hit in these disparities include underserved regions, such as where Native American communities reside. This is one of, you know, this was one of the outcomes of the IOM report, you know, regarding these disparities, and is actually a focus of concern for the American Epilepsy Society, as well as the ILAE North America. And so indeed, much more attention needs to be focused on improving and delivering care. There are some specific programs, including a program called ECHO, that focuses on areas of disparity for chronic illnesses, and epilepsy is one of them. And so that's a program that hopefully will bring some improvement to these harder hit areas.
Sam, do you have any comments on the situation in Canada with the First Peoples?
Yeah, so the First Nations people in Canada are covered, all services are covered. In fact, they have access to services that fall into the category of supplementary services in general, which means that, for example, medication coverage and dental or other services that are typically not included as essential medical services for the general population are covered just like they are for the seniors and other groups. Now, this varies importantly from province to province. Remember, this is I think that this is one of the issues in Canada. The issue is that even though the Healthcare Act is a federal act, healthcare services delivered provincially, and it's organized and funded provincially to a large degree. And so there is a substantial variation in terms of coverage of individuals, groups, and so forth, for example, pharmaceutical coverage. But no, sort of First Nations or Aboriginal populations are generally covered in the healthcare system. And I must say that, you know, my talk was the ideal healthcare system in general, not focused on epilepsy, because that was the original theme I was assigned, and then it was turned into, is this a model of care for epilepsy? But, you know, the general elements that I outlined in the talk are applied very much to epilepsy across the board in terms of this level of specialty, specialist care, and access to other services.
One of the problems for Native Americans and other minority groups in the US is a fair amount of suspicion of what you might call the healthcare establishment, reluctance to join clinical trials, or even sometimes to seek care. That's been a problem for epilepsy. It's a problem for COVID trials as well. Is that an issue in Canada too?
I'm sorry, what issue specifically? I missed some of the words you mentioned.
Sorry, suspicion by minority groups of the healthcare system, the healthcare establishment.
Yes, I think that is an issue that we face for a number of things. It's not just COVID now, but in general, you know, research and access to these populations for various aspects, including even surveys, for example, are not straightforward. And there are a number of steps and agencies that you need to engage in order to access that, but it can be an issue. We are trying to increasingly work with their complementary medicine or alternative medicine methods to try to you know, interact with them in a positive manner and make the best. I would say, you know, trying to gain the best from both worlds in that sense. But yes, it is not easy to engage. In fact, you know, as you know, that many of the omnibus health surveys in Canada that are actually very, very helpful, and they're longitudinal, often exclude people in reserves as they exclude other groups. Yeah.
Bill, I'd like to just comment on one thing, which is, you know, when we talk about access to healthcare and access in epilepsy, we have to consider coverage, as Sam was mentioning, and stigma and fear, as you were mentioning, but also just the fact that there are areas that have very little access to specialists. So if you have one neurologist serving a very large area, that will certainly limit, you know, that creates a disparity. And to, you know, I mentioned a few moments ago this ECHO program, and just to sort of expand on what it is and its goal, at least in the US, this is a telementoring program that links primary care providers with epilepsy specialists. And I think that's a tool that is probably underused, because it's likely that these communities will trust their local providers more than some, you know, outside specialists. And if we can educate the local and trusted physicians and healthcare providers in epilepsy, such as through programs as ECHO and others, that will extend epilepsy care into these harder to reach areas.
Amza, there's a question for you about meetings, and perhaps you would also like to moderate, take over moderating the questions.
Thanks, Bill. I'll answer Dan's question in a sec. I'd just like to add to some of what Cheryl and Sam have said. You know, people don't remember that the Caribbean also had an indigenous native population, but unfortunately, in most of the islands, they were entirely wiped out during the early stages of the arrival of colonialism. Let's put it that way. And there are still survivors, particularly in Guyana, in South America, which is an English-speaking Caribbean territory. But they have been largely, I shouldn't say largely, they are being progressively integrated into mainstream society. And their needs are met in the usual way in which healthcare is provided in Guyana. But there is a history of an indigenous population. The Arawaks, the Tainos, the Caribs, and other groups who really don't exist anymore. We only find artifacts of them in the islands, including, in fact, we found one in my garden. But so that's that. Otherwise, to speak about healthcare metrics and so on. You know, another thing that people don't recognize is that the Caribbean is an upper middle income territory, and life expectancies and health outcomes are reasonably good. So a woman would live until the age of 78 on average in Jamaica, and in fact, it's not the highest, because Antigua, a woman's life expectancy is 80. So people do live fairly long and productive lives. But the issue, and that's the reason for my motivation for doing my current doctorate, is that advanced specialized healthcare is not something that governments can afford. And how do we meet that need? So presently, most governments in the Caribbean spend between 5 and 6% of GDP on healthcare. And you get a lot for it. Most of the focus, of course, is on preventative things, primary health care, dealing with the regular stuff and so on. On average, roughly half of economic expenditure by a patient is directed to the private healthcare system. And so there's this mutual private and public healthcare system that exists in most islands that meets the needs of people depending on their capacity to afford. There are clear differences in outcomes depending on whether you can afford a fully private healthcare approach or whether you have to go completely to the government. So there are disparities related to health outcomes related to economics and individual economics. So one of the interesting things is that in Jamaica in 2012, the average amount of money spent per person was $512 per person. And that still placed Jamaica in the top 25% of the rankings of the WHO in terms of health outcomes. And that's because you deal with infectious diseases, you deal with primary health care, and basically you can make people live much longer by doing those things. When it comes to addressing the care needed as we age, with neurodegenerative things and things like epilepsy and so on, of course the capacity to afford that is much less than the developed countries like Canada and the US. To answer Dan's question, you know, this virtual format, I've had a lot of feedback from people in the Caribbean. They love it. They are excited by just being able to join. It's not economically feasible to travel and you know, there are costs associated with attending any meeting that go beyond the registration. So many people do like it. However, I mean, many of us recognize the irreplaceable value of networking and relationship building. And so there's no question that we will have to have in-person events. But I think this has been worked out already by the North American, the ILAE North America, in terms of a strategy of how we will move from the US, Canada, and to the Caribbean. And the idea is to have smaller meetings within the Caribbean on a much more regular basis in between these major biennial meetings that will help to keep the needs of epilepsy in the forefront of the Caribbean healthcare practitioners.
Mm-hmm. There's a question from Elaine Wooldridge about the International Year of the Nurse and Midwife and asking about the next steps of a universal education program for nurses around the world. Who would like to tackle that one? Sam, does ILAE have any, or IBE have any programs along those lines?
So I'm rereading the question, next steps of universal epilepsy education program for nurses around the world. This is a great question, really, you know, because as you know, we are creating standardized competency-based epilepsy curricula for epilepsy professionals, but mostly for clinicians in primarily responsible for the care of the patient. In other words, whether it's a GP or a neurologist or a child neurologist, that has been the focus in the initial step. We are right now creating a curriculum, and there's a survey that went out with the initial draft of the curriculum for people to get feedback on primary care. Now, primary care is very broad, and that includes nurses, for example, in the front lines providing care. It could also include, for example, public health officers that are in some countries responsible for providing care to people with epilepsy. In some other areas, it's the traditional healer or the school teacher or the priest. So it is a very, very broad group of people, and we are creating a set of competencies for that set of primary care. Now, specifically for nurses, the ILAE just created a special support group, or a special, I would say a special interest group, if you wish, of nurses. This is led by Marielle Prévost from France. And the group is increasing, and they are defining their course and what are the things that are important for them to tackle as epilepsy professionals, providing care. They're a crucial element, of course, a crucial element in the epilepsy care chain. And we don't have yet a specific curriculum or set of educational activities for nurses, but I certainly hope we will. And that will be part of the agenda of education in the next iteration. But it's an excellent question.
So there's a question from Mary Secco asking whether there has been progress in improving health-related quality of life for people with epilepsy over the last 15 years, specifically in the US. Cheryl, can you address that?
Yeah, I saw the question, and I was quickly looking to see if we have actual metrics on that. So, going back to the IOM report, that, health-related quality of life, employment, et cetera, was one of the major features. And in fact, one of the important areas of the need of research was deemed to implement community-based studies to improve health-related quality of life, which we see being done. And as I showed, the CDC program that came out since our last report is directly focused on health, quality of life issues for the patient. These self-efficacy, self-empowerment programs, cognitive training, mood, depression, anxiety, interventions, etc. I am not aware, other than the large multi-center study of epilepsy surgery employment data, I'm not aware of specific data, and maybe some of the other presenters are, about, published improvements in such measures in the last 15 years for persons with epilepsy. One hopes that this has improved with greater public awareness, reduction in stigma, et cetera, but I don't know specific numbers, and I defer to if anyone else here does.
Mm-hmm. There was a recent article, I think, by Anne Berg and others, suggesting that there had not been perhaps as much improvement as one would have hoped for, both in access to care and in other issues such as automobile accidents involving people with epilepsy. So that's the only thing that I can think of off the top of my head.
From a Jamaican perspective, one metric that we have to us is when I did my first audit of the situation in Jamaica, the unemployment rate for people with epilepsy in the public health sector clinics was 85%. 85% were unemployed. Last year, when I had an informal look at the data again, the figure had improved to the extent that the unemployment rate was now 20%. So that was, I felt, a very important metric of whatever was happening in the Caribbean and Jamaica. But I know that part of that was not necessarily the specific effects of advocacy for epilepsy, but rather the improving economic situation in Jamaica. And that may well be substantially set back because of COVID.
Mm-hmm. So there's a question which is specifically about the Canadian situation. Sam, would you like to address that?
Sure. So Deirdre is asking about a situation in which she says, I have a pre-existing condition and I cannot get a private plan. The only way I can get a percentage coverage of my drugs is through my husband, who's paying a significant amount for a plan that asks no questions. So I fall in between getting a pharma card and actual coverage. Is this a failing of the Canadian healthcare system? And all Canadians that are in the session right now will identify with this immediately. Yes, the answer is yes. You know, there is this crack in the system where if you are employed and you have an insurance and your organization pays, etc., you're okay. If you are disabled or in a very disadvantaged social group, homeless, etc., or a senior, you can get coverage to some degree or to a large degree. And if you're in between, where you're neither, then you're in a tough position. And this definitely is the case, certainly for medications, for example, as Deidre mentions, but for other things as well, right? So support is kind of missing in that area. Now, specifically with regards to access to medications, this is an important thing that we have to weigh in all our clinics in provinces where we do not have universal pharma coverage. This varies from province to province, again, but in general, across the provinces, there is a lack of universal coverage of medications, and we have to weigh this at every visit. Can the patient afford this? You know, do you have a drug plan, yes or no? Or are you in the category where supplemental income or government support will pay for your medications? There's a very strong move recently, as we all know that live in Canada, to have a universal pharma plan coverage across the board. And I hope that this really comes to fruition. The cost benefit analyses have been done, and it's very clear that it is an affordable system that would benefit people enormously. I should mention that the country in the world, probably, the country that has a publicly funded healthcare system, the country in the world with the largest number of benefits covered is France. And you will notice that it doesn't appear in the happiest group for whatever reason. I don't know why. So this issue of satisfaction and happiness, it's a tricky issue, right? But yes, Deirdre, you're absolutely right. That needs to be addressed.
You know, I would say that we, in the U.S., in the medical world, we were quite fearful of what the ACA would bring. There were a lot of different approaches and different ideas about whether healthcare would receive lower reimbursement. And none of these fears were really realized, but in contrast, the advantage of providing healthcare opportunity for exactly that group that Sam described, the people who don't get health insurance through their employer, don't make too much money to qualify for the public health assistant, fueled coverage, but sort of fall in between. And these were the people that traditionally did not have health insurance, and it was a tremendous problem. And really, that has gone away. I mean, the plans that are available to purchase on what they call the healthcare exchange are reasonably priced. They may not be, sort of the gold standard plans and that everything is covered, but pretty much you can get nearly any medication that's appropriate through those plans. And it really has made a tremendous difference. So from our point of view, the ACA has successfully addressed that.
Well, yes and no. Particularly with the newer medications, there is still be very substantial co-pays. And that people cannot afford. And there are still people who will eke out their medications, not take the full amount. So it's it's not so wonderful all the time.
No, I agree with that.
Yeah.
And in the Caribbean, one of the things we've been able to do is to actually get governments in most islands to support the payment for the costs of anti-seizure drugs. And like, for example, Jamaica has 12 drugs that are available through the National Health Fund, in which the vast majority of the cost is covered by the government. And most of that has happened since we started our initiatives. I mean, and I say we, I mean really we, all of us on this, working together towards making that happen in the Caribbean.
So, I have a question. Oh, Sam, sorry.
Sorry, no, I would just want to, so Jorge Burneo has made a couple of comments there, and one is about the fact that epilepsy care in Canada is actually improving significantly in some areas, and I would like to acknowledge that. That is absolutely correct. There are there are exemplary initiatives taking place, for example, in Ontario, and Jorge mentions the ECHO program and the epilepsy program provincially, and then similar efforts probably taking place in Quebec and so forth. I know that some provinces are initiating epilepsy programs that were fledgling or virtually non-existent before, and so forth. And so I would like to acknowledge that, but I would like to acknowledge also the fact that all of this is, I don't think it's an exaggeration to say that all of this is on the backs of people who believe fervently, passionately in the cause of epilepsy, and that organize themselves and go to governments and go the effort and explore avenues and explore, coalitions and collaborations to go together and implement these things. And you need to use the opportunity. There was an opportunity in Ontario and it was done. And there might be an opportunity in Quebec, I really don't know. Right now, there would be zero opportunity in the province of Alberta, where I live, which is in serious economic trouble because of the oil price collapse and because of COVID. So there would be zero opportunity now, but as the opportunity arises, I think it behooves all of us who are in this call, right, in this session, to organize ourselves and to lobby for those things. And this is how epilepsy care improves. So thank you, Jorge, for bringing that up.
Yeah, so AMSA has actually been someone who has exemplified the initiatives and energy that you just described as being necessary. And so I'd like to ask AMSA a question, which then perhaps extending to the whole panel. So one of the things that you've tried to do is to actually implement epilepsy surgery programs, video EEG monitoring. Now, so before COVID, could you perhaps talk a little bit about how that was going and how much either support or resistance you got from the government, who might have said to themselves, well, look, this is very nice, but it's a pretty high-end thing. It only is going to help a limited number of people, and perhaps we should put some money into treating hypertension or something like that. And then perhaps in the time we've got left, the rest of the panel could just comment on why there is still such a gap between the number of people in the US and Canada who could benefit from epilepsy surgery but are not getting it. So AMSA, perhaps you could start us off.
Thanks, Bill. So we were moving along quite merrily and things were happening. We had some hiccups in terms of getting people trained. So for example, getting an epilepsy surgeon trained. We did eventually get that to happen. Dennis Spencer at Yale has trained Dr. Dwayne Cook, who in fact is speaking on as faculty here later today. We had a neuropsychologist trained in terms of the required evaluations at Yale as well. And things are moving along well. What we had was a video EEG center that I ran in the private system. And I knew that for us to make this a truly economically accessible entity, it had to happen within the public healthcare sector. And so we were fortunate to develop a relationship, myself and a Jamaican neurologist who is at the University of Colorado, Misha Gay Brown, who's now associate professor of neurology and epilepsy there. And we have arranged for equipment to be donated to the Kingston Public Hospital, where we will be doing pre-surgical evaluation and long-term monitoring with the equipment. And that's what I alluded to in my presentation, that we were supposed to have had that equipment since July, but it's not going to come until December now because of COVID and all the quarantining that we have to endure and so on when you travel. But we now have a plan and everything is in place, and Dr. Cook is there, and the whole team has been reactivated, and we are looking forward to doing formal epilepsy surgery with formal evaluations as needs to be done. However, epilepsy surgery is already taking place in the context of recognizing lesions with into the EEG and appropriate imaging. In fact, Dr. Dwayne Cook's wife is a neuroradiologist who's also Yale trained and board certified, and she has been helping us enormously towards understanding epilepsy-related neuroradiology and building an enormous following in Jamaica and the rest of the Caribbean through teleradiology. So I think there are many key features that are in place. And although COVID has made life a little difficult, I think in some ways it's also helped us to accelerate the relationships, the regional relationships, which will only in the end help.
Yeah. So Cheryl, why do you think it's so hard to get more people to epilepsy surgery?
It's funny you ask me this now, because we're in the process of trying to get a paper published from a study that one of our residents did on barriers to epilepsy surgery in my community where I practice in the Bronx. And what we looked at were patients who were surgery eligible, who went through the surgical process up until being recommended to have surgery, and then those who went ahead and had it and those who elected not to, and what were the aspects that impacted that. And I'll just reveal, fascinatingly, one of the major variables was employment status, in that people who were employed were less likely to opt to go forward for surgery. And again, these are typically patients in the communities we serve who don't have guaranteed sick leave. They're not working for large corporations typically. And so for them, taking the time off for surgery and recovery may have been the barrier. And in addition, like you've mentioned, distrust, concern. So that's one very major aspect. And another, I think, in many parts of the country is that the referring physicians, maybe we have not educated the primary care doctors enough to even, refer them. So I think there's a variety of reasons why this gap exists.
Mm-hmm. Sam, do you have any thoughts about that?
Yes, it's multifactorial, Bill. I think that for a long time we've said, well, people, I agree completely with what Cheryl said, those factors, but, we've said, well, people don't get referred, they don't get referred, which is true, but also people don't want to have surgery in the first X number of years that they have epilepsy. And then, these statements keep coming up. Well, if you fail 2 drugs, you're not really drug resistant. There's still a chance of this and the chance of that. And, people are afraid of having a chunk of their brains removed. And I don't blame them, right? Well, I think that education is the key, like that continuous education, about emphasizing a clear picture, not a biased picture of surgery with the risks and benefits, I think is very, very important. And educating not only our physicians and the referral base, but also our patient community.
Mm-hmm. I just have to add one last little caveat to what I said about the extermination of Native people in the Caribbean. Dave Clark reached out to me through WhatsApp to tell me that there are still Arawaks and Carib people in the Grenadines and Dominica, the little island of Dominica. So I take that back.
Do you have any statues of Columbus?
As far as I can remember.
I think we've come to the end of our time, and I'd like to thank all of the panelists and also the participants for being with us this morning, and I hope that you found this session enjoyable and useful. So thank you very much.
Bye-bye.
Yeah. Bye-bye.
Hello.